Good afternoon, everyone, and welcome to today's Public Health Ontario Microbiology Rounds presentation on the national surveillance of Neisseria gonorrhoeae antimicrobial resistance in Canada. I am Dr. Angela Ma, clinical microbiologist at Public Health Ontario, and I have the pleasure of moderating today's session. I would like to give a land acknowledgement recognizing that the land I and many of us at Public Health Ontario are gathered on is the traditional territory of many nations, including the Mississaugas of the Credit River, the Anishinaabe, the Chippewa, and the Haudenosaunee and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. In the spirit of peace, friendship, and respect, we will strive towards conducting our work here at Public Health Ontario with active engagement and relationship building with our Indigenous partners. I am pleased to introduce today's speakers, Robin Thorrington and Shelley Peterson. Robin Thorrington is a biologist in the Streptococcus and Sexually Transmitted Infections (STI) section at the National Microbiology Laboratory in Winnipeg. Her work focuses on monitoring antimicrobial resistant gonorrhea through the Gonococcal Antimicrobial Surveillance Program, otherwise known as GASP-Canada, a passive surveillance system. She uses phylogenetic analysis to investigate trends and outbreaks in gonorrhea antimicrobial resistance and ensures the section's compliance with ISO 17025 accreditation standards. Shelley Peterson is also a biologist in the Streptococcus and STI section at the National Microbiology Lab in Winnipeg. She has led various STI research projects, including the development and evaluation of molecular tests to detect mutations associated with antimicrobial resistance in Neisseria gonorrhoeae and Mycoplasma genitalium as well. Shelley also performs whole genome sequence analyses for Neisseria gonorrhoeae, contributing to a deeper understanding of resistance mechanisms and strain characterization. And without further ado, I'd very much like to pass the presentation on to our wonderful presenters, Shelley and Robin. Please take it away.
I'm here with my colleague Robin, and I'm here to present on the national surveillance of Neisseria gonorrhoeae AMR in Canada. Here's a few disclaimers for our presentation. Neither Robin or I have any conflicts of interest to declare. Here are some learning objectives for our presentation. So by the end of the presentation, you should be able to summarize recent epidemiological trends in Neisseria gonorrhoeae activity in Ontario and the rest of Canada. Describe the current approach to Neisseria gonorrhoeae whole genome sequencing and reporting at the National Microbiology Laboratory. Recognize the threat of the global spread of XDR Neisseria gonorrhoeae strains and the potential impact of increased ceftriaxone resistance on the efficacy of current recommended therapies. And understand the value of NAT testing for expanding the breadth of surveillance data where cultures are unavailable, particularly in northern, remote, and isolated regions of Canada. We would like to acknowledge that the CSC-HAH is located on the traditional Treaty 1 territory of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the territories and treaties, we acknowledge the harms and mistakes of the past, and wish to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. And at this point, I'll pass it off to Robin to introduce our gonorrhea surveillance program.
Hi, so the Gonococcal Antimicrobial Surveillance Program, or GASP-Canada, is a system set up to characterize antimicrobial resistance in Neisseria gonorrhoeae in order to monitor trends in AMR, support outbreak and treatment failure investigations, and also assist with the development of treatment guidelines. Neisseria gonorrhoeae is the second most prevalent bacterial STI in Canada. And in Canada, gonorrhea isolates have been showing increased resistance to frontline therapies in recent years, including the detection of multi-drug resistant and extremely drug-resistant isolates, and several reports of treatment failures to recommended therapies. GASP-Canada is a voluntary passive surveillance system monitoring antimicrobial susceptibilities in Neisseria gonorrhoeae that was established in the mid-1980s, and we receive approximately 3,000 isolates annually. Currently, our culture collection stands at over 60,000 isolates, and a subset of these isolates are part of what is called the Enhanced Surveillance of Antimicrobial Resistance Gonorrhea System, or ESEG, which will also be touched on briefly later in this presentation. So an overview of our program is that all provincial and territorial laboratories across Canada and the New Brunswick Regional Hospital Labs submit resistant or untested culture Neisseria gonorrhea cultures to the National Microbiology Lab, and also several provinces send us their susceptible culture data as well. Once the cultures arrive at the National Microbiology Lab, we perform molecular and microbiological characterization of those cultures using two main methods. The first being whole genome sequencing, which is now our routine testing method and will be discussed by Shelley later in this presentation, and our traditional and the gold standard agar dilution testing, which I'll discuss more shortly. Once we have the results from these tests, we of course report back to the submitting laboratories, while also sending our results in annual submissions both to the Canadian Network of Public Health Intelligence, Canadian Antimicrobial Resistance Surveillance System, or CARS, as well as GLASS, which is run by the WHO. So GASP-Canada is a collaboration between FAC and the provincial and territorial public laboratories across Canada. We receive data on Neisseria gonorrhea cultures within Canada in two ways. The first being physical cultures sent to us here at the NML, and those are sent based on three criteria: resistance to at least one antimicrobial tested, approaching resistance for key antimicrobials, those being the treatment antimicrobials, azithromycin, and the two cephalosporins that are preferred, ceftriaxone and cefixime. Or for some jurisdictions that don't do their own susceptibility testing, they will send us culture with no AMR data. The other way we receive data annually is from three of the provinces that send us their susceptible culture data, which is from all their cultures that they did not send, as well as the key demographic information that we request, shown here on the right. Once the cultures are here, we perform our AMR testing, and we also log in that submitted data, and then those two data sets are combined for analysis for sending out in our annual report, which is published in CCDR, as well as submitted into GLASS, CARS, etc. Our antimicrobial agents are tested based on CLSI guidelines using the recommended controls, and we request the total number of cultures tested in each jurisdiction annually to determine the denominator used in all our AMR trending analysis, and that denominator is what is used for the totals each year in the results section of this presentation. Data sourcing. So all data presented here is generated by the Streptococcus and STI section, which houses GASP-Canada at the National Microbiology Lab, as part of their work monitoring Neisseria gonorrhea AMR in Canada. This data is based on cultures and clinical specimens sent to the section from jurisdictions across Canada on a voluntary basis. All culture data presented here is part of GASP-Canada. For GASP-Canada, we have two sets of antimicrobials that we test. The first is what we use for agar dilution for the phenotypic testing seen here on the left. So that's 10 antimicrobials. And on the right is the antimicrobials that we predict MICs for based on our whole genome sequencing results. So agar dilution has three additional antimicrobials: erythromycin, which we do not generate predicted MICs for due to the fact it is very closely linked to azithromycin. And if a isolate is resistant to azithromycin, it will also be resistant to erythromycin. The other two that have been excluded for now from whole genome sequencing predictions is ertapenem and gentamicin. And these results are not reported out on our phenotypic reports either. And that is due in part to the fact that neither UCAS, so the European guidelines, or CLSI have either ECOFs or breakpoints for those two antimicrobials. GASP-Canada also runs a Gonococcal antimicrobial susceptibility comparison program, so a proficiency panel program, in which 10 labs participate in across the country every year. And this panel looks at AST determined on either agar dilution and e-test, and then compare all the results against each other to determine a consensus and make sure that all labs are in agreement with each other across the country in terms of AMR monitoring. We have very good concordance across all the participants. And GASP-Canada itself also participates in an annual external quality assurance program administered by the CDC. ESEG, or the Enhanced Surveillance of Antimicrobial Resistant Gonorrhea, encompasses a subset of samples sent for GASP-Canada. It is an integrated epidemiological and laboratory surveillance system, and it is hosted on SynFi. Resistance data from this system will inform development of Canadian STI treatment guidelines, and it monitors for the adherence to STI treatment guidelines across the country, both for provincial and federal guidelines, and looks at which antimicrobials are used. It also monitors resistance in key at-risk population, as it does collect data on sexual behavior. It also works to identify treatment failures and outbreak clusters. The shown here in purple are the 6 participants in this program, and this program was launched in 2013, with data collection starting in 2014. And as I mentioned, this program is hosted on SynFi. Now, I've talked about how we use agar dilution for determining MICs, or minimum inhibitory concentrations, for all cultures sent as part of GASP-Canada. We also, in order to track the spread of the strains across Canada, use a typing system called Neisseria gonorrhea multi-antigen sequencing typing, which can be used to characterize different strains of GC. It uses 2 highly variable regions of gonorrhea, porin B, or pore B, and transferrin binding protein B, or TBPBB. The identity of these 2 alleles make the sequence type of the bacterial strains. And for our purposes, we have found within GASP-Canada program that this typing system marries very well with AMR profiles and allows us to track the spread of different strains across Canada. Now I'll pass it back to Shelley.
In November 2022, we began performing routine genomics analyses on all of our gonorrhea cultures. So in addition to NG-MAST, this allowed us to add 2 more sequence typing methods to our analyses for characterizing isolates, including MLST and NG-star, which is an AMR-specific typing method that I'll discuss in more detail. We're also able to predict AMR MICs using genomic data. We sequence using the NextSeq platform, and our analyses are performed using an in-house developed program called WADE, which I will also be talking about. In addition to our routine analyses, we can also generate phylogenies and other analyses to help with outbreak support. Here's a brief outline of our workflow. We batch our samples into groups of about 90, which we send to core facilities in our building, including Robotics Core, which performs our DNA extractions, and the DNA Core facility, which does library preps and sequencing. Our lab technicians then run the data through Galaxy workflows and perform analyses using our in-house developed WADE pipeline and upload into our LabWare-LIMS system. And this turns into about a 2-week turnaround time between batching samples and reporting results. Here's a little bit about the NG-star typing scheme. NG-star stands for Neisseria gonorrhea sequence typing for antimicrobial resistance. It was developed in-house by Walter Demchuk, who used to work in our lab but is now retired. It's used to track the global dissemination of antimicrobial resistant Neisseria gonorrhea strains using standardized nomenclature, and this is used all around the world. It consists of 7 genes, the sequences of which are assigned allele numbers, and the combination of allele numbers produces the NG-star type. The chosen genes are associated with resistance to antimicrobials, including PEN-A, PON-A, and POR-B, which are associated with decreased susceptibility to cephalosporins, MTRR and 23S are RNA, which are associated with azithromycin resistance, and GAR-A and PAR-C, which are associated with ciprofloxacin resistance. The NG-star website is hosted by the Canadian government at ngstar.canada.ca, and we've received submissions from all over the world, with the majority being from Canada, Sweden, and the USA. There are several members of our lab that are curators of this database, and there has been a publication for it as well. And the WADE program that we use for our analyses stands for Whole Genome Sequence Analysis and Detection of Molecular Markers. This was also developed by Walter from our lab. It's an in-house developed R-Shiny app, which enables our bench-level lab technicians to perform whole genome sequencing analyses from assembled contigs. It can be used for all of our whole genome sequence analyses, including AMR prediction, MLST, NG-STAR, and NG-MAST, as well as non-routine research analyses like searching for novel mutations and new AMR markers. It can query hundreds of genomes per batch and can be used for analyses of both gonorrhea and streptococcus species, and could easily be adapted to other species as well. It's now available to external collaborators and clients on GitHub. Now that Walter has retired, I've taken over the maintenance and updates of WADE and its associated reference files, so you can contact me if you have any questions about it. What I would consider to be the most important thing that we use WADE for is MIC prediction using whole genome sequencing data. This was also developed by Walter from our lab. He used multivariate logistic regression analyses to generate predictive equations for MICs. Using our extensive data set of phenotypic and whole genome sequencing data, he was able to correlate various SNP profiles with phenotypic MICs to create equations that accurately predict MIC values. So these don't just predict whether a sample is resistant or susceptible, they actually predict an accurate MIC value for the sample. However, these equations are only as accurate as the data used to train and test them, which means we need up-to-date phenotypic results that reflect what is currently circulating in Canada. Because of this, we do still perform phenotypic testing on a subset of our isolates to support validation of these pipelines. We review our equations annually and ensure that the predictions are still accurate, and if required, we'll update the equations and incorporate new resistance mutations that may be circulating. Neisseria gonorrhea is highly competent and acquires new AMR markers easily. Also, different regions in Canada may have different treatment recommendations and antimicrobial resistance profiles of their circulating strains. Because of this, we need cultures from all regions of Canada to ensure accurate prediction of MICs across the country. We do still do phenotypic testing for isolates that approach or are above the resistance breakpoints for azithromycin, ceftriaxone, and cefixime, confirming results if they're needed, or if a sample fails sequencing, which could indicate a new mutation of interest. Here's a plot of the number of gonorrhea cases in Canada over the past from 2011 to 2021. And you can see that the reported rate has more than doubled since 2013. There was a little bit of a dip in 2020 and 2021 with the COVID-19 pandemic affecting diagnosis and reporting of STIs. But one important thing to note is that 90% of cases are diagnosed by NATs, which means for these there is no culture. So we can perform neither phenotypic MIC testing nor whole genome sequencing on these samples. This is particularly noticeable in northern, remote, and isolated regions where cultures, the resources for culturing just are not available. So what do we do with these samples? So we receive the NAT specimens, which are either urines or swabs. We extract the DNA, and then we use them for PCR. So we have a nested conventional PCR that we use for NG-MAST testing, as well as a set of real-time PCR assays for SNP detection. And we can use these assays to predict AMR in NAT specimens. We focus on antimicrobials that are part of the current recommended or alternative treatments. So for cephalosporins, we look at PHO, POR-B, MTRR, and PEN-A. For azithromycin, we look at 23S and MTRR promoter variants. And for ciprofloxacin, we look at JAR-A and PAR-C. Since we're only detecting a few SNPs for each gene and not the entire sequence, we can't predict an actual MIC like with whole genome data. but we can quite accurately predict susceptibility or resistance. This is really straightforward for ciprofloxacin or azithromycin, as presence of any of the associated SNPs we test for is indicative of resistance. For the cephalosporins, it's a little bit more complicated, with presence of Pen A311V indicating a resistant specimen, presence of A501P in Pen A or any other two SNPs associated with decreased susceptibility, or for intermediate or decreased susceptibility, so an elevated MIC, we look for 3 out of 7 of the SNPs, or for cefixime particularly, we look at Pen A N513Y, PON AL421P, and NG MAS TBPB10. We've also had several publications using these assays, and throughout the years we have made changes to them as the antimicrobial resistance profiles and mutations present in gonorrhea have changed. Here's a comparison of gnats versus cultures. Gnat collection is less invasive, more efficient, and can be used for gonorrhea cases from remote regions with limited resources. Whereas culture is an invasive collection method that requires resources to collect and transport to maintain viability for testing. Gnats can detect isolates that are not viable, but also may not differentiate between organisms in a mixed specimen, whereas organisms in a sample must be viable to be tested by culture, but you can separately test organisms that are in a mixed culture. Molecular tests only detect the specific known targets that we're looking for, whereas cultures can be used with a range of antimicrobials, and whole genome sequencing provides all the genetic information. Generally, gnat data is meant for larger scale surveillance, while cultures can be used for individual patient care. Some limitations of using gnats include pharyngeal specimens are not recommended for this test, as they may contain non-gonorrhea Neisseria species which can be detected by these tests. Cephalosporin resistance is determined by the combined effects of multiple genes, so sometimes we can get incorrect predictions as samples with the same SNP profiles can exhibit a range of MICs. Samples with a low concentration of DNA can limit SNP detection, and emergence of new strains with sequence variations in the primer or the probe regions can lead to false negative or false SNP results, just like with our whole genome predictions. We routinely evaluate and update these assays to include currently circulating mutations and generate the greatest possible accuracy of our predictions. Since 2017, we've received and tested over 10,000 gnat specimens. Most of these have come from northern regions. However, we've seen quite a few from Alberta and Nova Scotia as well. When we look at NG-MAS typing, the most prevalent NG-MAS STs that we find are ST204 and ST1993. There were 230 different STs detected in 2023, but this figure is only showing the ones that have more than 10 samples. Of those 2 most prevalent STs, they were both only detected in northern regions. And ST1993 was first detected in 2017 and is associated with predicted susceptibility. ST20400 was first detected in 2022 and is associated with predicted elevated cephalosporin MICs and ciprofloxacin resistance. In Eastern Canada, we've seen a lot of ST20336, which was first detected in Ontario in 2021 as an azithromycin susceptible culture. However, in 2023, both cultures and gnats with this ST type in Eastern Canada were seen with high-level azithromycin resistance due to the presence of 23S rRNA A2059G. Now I'll pass it back to Rob.
Hi, so this figure here shows the cultures that were sent to us here at the NML over the past between 2018 and 2022. And highlighted in this box here is the number of cultures sent to us from Ontario during that 5-year span. As you can see, like everyone else, there is a dip in 2020 and 2021 due to the COVID-19 pandemic. However, beginning in 2022, we are seeing an increase in the number of cultures collected. Across Canada, here we have the antimicrobial susceptibilities for antibiotics of note. As you can see, azithromycin and tetracycline are both seeing increases in the level of resistance nationally. However, everything else, including the 3 preferred treatment antimicrobials, azithromycin and the 2 cephalosporins, are currently holding relatively steady. For Ontario at a zoomed in level, again, by and large, things are holding steady. Of note, though, is that there is no erythromycin data for 2022 presented here due to the fact that, as I mentioned earlier, there is no predicted MICs for erythromycin from whole genome. And any phenotypic data we would have would be biased due to the fact that there would be a decreased denominator, as well as the bias towards testing known resistant samples due to the linkage to azithromycin resistance. Of note here, which is a little bit different than the rest of the national picture, is penicillin in Ontario looks to be creeping up a little bit, but otherwise things seem to be holding steady within Ontario. This figure here shows the resistance for tetracycline nationally, with each of the individual bars on the bar graph showing by province or territory with the rates of resistance for the PT. Now, the reason I'm showing this slide is, and we're not discussing doxycycline PEP in this presentation. However, tetracycline is related to doxycycline. And we have been getting more questions around tetracycline resistance levels. So I thought this might be of interest to this audience to see what Ontario levels are and what national levels are. So in general, in keeping with the previous slide, Ontario generally tends to trend with the rest of Canada on this. A little bit of variability seen here in this light blue, but generally it's ranging between 50 and 60% resistance within the cultures that are sent to us here at the National Microbiology Lab. For decreased susceptibility to ceftriaxone between 2018 and 2022, Ontario is seen here in the green. And again, it mirrors the national average with a high point in 2022 of just over 1%, and then a steady decrease since then. The same story is true also for cefixime. So again, Ontario is here in the green. We saw a spike in 2020 and then a steady and fairly rapid decrease since then in terms of the rates of decreased susceptibility to cefixime nationally and within Ontario itself. So now it looks like it is below 0.5% in 2022. Azithromycin is a bit of a different story. It's been holding on average, though the trend line goes a bit all over the place, fairly within error of significance, fairly steady. However, and this since 2016, which is not included on this figure, the WHO has a recommended level of resistance for review of inclusion of a treatment of an antimicrobial in a recommended treatment at 5%. And since 2016, azithromycin has been above a 5% level of resistance all across Canada, with a great deal of variability from jurisdiction to jurisdiction. Ontario is shown here in the dark blue. And again, it mirrors the national trend line quite well, and currently is sitting at under 4% in 2022. This figure here shows a breakdown of the proportion of isolates sent to us that are at a particular MIC per year. So this one here shows an MIC of less than or equal to 0.125 milligrams per liter, 0.25 milligrams per liter, etc. So this is the national picture of a breakdown by MIC proportionally. And as you can see over time, it has been trending upwards in terms of MICs for azithromycin, with more and more cultures being at an MIC of 1 or just below the cutoff mark that we currently use by the CLSI guidelines. Ontario, zoomed in, is actually a slightly shifted perspective. So most of and it tends to have a slightly higher set of MICs than that figure there. However, your MICs of 1 are quite, in 2022, were a fair bit lower than in 2021. So it's very nice to see. So one of the things of note that we've kind of been looking at is that a lot of the other regions globally have been, including Australia and the UK, have been using a breakpoint of an MIC of 1 milligram per liter for azithromycin, whereas CLSI and we use a MIC of 2. And this 1 milligram per liter is based on the UCAST ECOF, say epidemiological cutoff value. So this is our trend line within Canada at a national level for azithromycin MIC of 2. And this is our trend line for an MIC of 1. And that our MIC 1s nationally are skyrocketing. So this is something we've been kind of keeping an eye on, just as other jurisdictions are using an MIC 1 as their breakpoint for resistance. Moving on to the typing systems that we use. This is the provincial distribution of NG mass types in 2022. And so the most prevalent NG mass type for cultures was 17972, and the second most common was 19875. And the 17972 was found fairly regularly in Ontario. Your other common ones are seen here in red. So one of the reasons we like NG mass is because it mirrors well with AMR profiles. And so this is looking at what AMR profiles are found within each of those ST types. So as you can see, the vast majority of STs are associated with resistance, and that's to other non-treatment antimicrobials, so ciprofloxacin, penicillin, and tetracycline. However, some are heavily associated, seen here in red, with azithromycin, and then others, though rare, are associated with susceptibility. Drilling into Ontario for 2022, these are the 10 most common STs for NG mast and NG star for within the province for that year. And as you can see, most of the 17629 is quite associated with azithromycin resistance. However, there's only about 15 cultures found within the province out of well over, I think, 400 cultures sent to us. Many of the other STs that are seen here are associated with ciprofloxacin or tetracycline resistance. So moving on to the current threat to big concern for treatment of gonorrhea is ceftriaxone resistance, as ceftriaxone is currently considered the main empiric therapy for gonorrhea infections. So in 2009, the first ceftriaxone resistant strain was detected in Japan, and that is PHO41. And then these are a few others that were detected between then and 2013. However, these are sporadic with no further transmission due to lack of fitness or opportunity. However, in 2015, in Japan, strain FC428 was detected, and this one has seen clonal spread across the globe. And in most ceftriaxone resistant strains that are detected globally are part of this clone. Within Canada, our first high-level ceftriaxone resistant gonorrhea was identified in Quebec in 2017. And it did lead to an initial treatment failure after initial treatment with cefixime 800 milligrams and azithromycin 1 gram. It was cured. The client, however, was cured upon follow-up with azithromycin 2 gram. This case was written up as a publication led by Brigitte Lefebvre out of LSPQ, and it was published in Emerging Infectious Diseases in 2018. And in this instance, the partner reported having unprotected sex during a trip to Asia in the fall of 2016, However, no culture was obtained from the partner. And at the time, a public health alert was sent out via CINFI. Since that time, with that initial case, we have now a total of 13 ceftriaxone resistant cases reported in Canada, and including one XDR case, which also included high-level azithromycin with the resistance to ceftriaxone. Additionally, in 2024 so far, we have currently, up until this present date, we have had 5 cases this year, and in last year in 2023, we had 3 cases. Most of these are linked to international travel, mainly to different areas within Asia. However, some were acquired locally or via travel within Canada. There have been a few treatment failures associated with these cases, with initial treatment not being successful. However, eventually the patients were able to be cured. Most of these cases were part of that FC428 clonal group that I spoke of, which contains the PEN-A60 allele, which is documented here, as you can see, is found in the majority of these cases. And up here at the top with this phylogenetic tree, showing cases here in purple, which are Canadian cases, and internationally recognized ceftriaxone strains that are commonly used as reference strains in comparing the spread of the FC428 clone across the globe. You can see that the majority of the cases in Canada that were included in this tree cluster together with that initial clonal origin that is seen here at the top. So one thing that we're beginning to do, and we're trying to advertise better, is that what do we do if we identify a ceftriaxone resistant Neisseria gonorrhea case, or that one of the public health labs alert us that they think they have a case. So if it has been identified by the PT, they will submit it to the NML, and we will prioritize phenotypic and whole genome testing, and an email notification is appreciated. If it is identified by the NML, we will prioritize confirmatory testing, and we will also notify the PT lab that we think we might have a ceftriaxone resistant case on our hands, and here's your confirmed results. After this testing is completing, we will work with the province or territory, along with all their public health infrastructure, in submitting to them a laboratory case report form called the Requisition for Neisseria Gonorrhea Treatment Failure Investigation or High-Level Cephalosporin Resistance. We also notify CCDIC, which is another branch of FAC, and we discuss with the province and territory whether they feel that they need additional enhanced surveillance. So that in most cases, we are offering up to do NATs for a limited portion of time if the PT is concerned about spread within the region around that detected case. We also discuss with them if they feel that a CINFI alert would be necessary. So this case report form just gathers up details around what treatments were used and whether or not there was travel involved. And this is used both for the provinces or territories' own internal use and also for our purposes in tracking these cases within Canada so that we can help monitor global spread of these cases. So thank you all very much for your time. I also want to extend a huge thank you to the Canadian provincial and territorial public health laboratories who make this program possible and all our work possible by sending us their samples. Shelley and I are part of the Streptococcus and STI section, and these are all the wonderful individuals that we work with, and we particularly want to give a huge shout out to our boss, Irene Martin. Thank you very much, and I'm now going to pass it to Angela for Q&A.
Thank you so much to Shelley and Robin for that extremely comprehensive and informative presentation on Neisseria gonorrhea, antimicrobial resistance trends, and the use of NAT and whole genome sequencing. As we move on to the Q&A segment of today's event to address some of the audience's questions, I would just like to provide a quick reminder to all of our attendees. If you haven't already, please continue to enter your questions into the Q&A pod, and we will try to work through them during our remaining time of this session. So I'm going to start with a first question that we have submitted into the Q&A pod, and I believe this question question perhaps will be directed towards Robin. It's asking what proportion of the increase in cases can be attributed to the increase in testing availability now? Do you have any thoughts on that, especially as, more access to potentially NAT testing is available, that, wasn't available before due to the limitations and difficulties of culture setup?
Yeah, that came up at a stakeholder meeting that we had recently. I guess my feelings on it are like it's uh probably a lot of it because like if you're testing more people for it, you're gonna find more of it. But I don't think that's a bad thing. Um, Shelley, do you have anything to add?
Yeah, I would say that the increase of testing definitely would lead to an increase of finding cases, but there is definitely a true increase in number of cases as well.
Thank you both for your answers to that question. Since we have, ended on the topic of ceftriaxone resistance, I think this question about the 2023 cases might be relevant to answer now, if possible. Are you guys aware of which provinces and or territories those 5 resistant cases in 2023 originated from?
Yes. That data, so we just don't necessarily always share that specificity of data with unless we have specific approval from those jurisdictions to share it in a given setting. So that's why we went with the generalized regions. I think a notification will be coming out soon about those cases. So if just kind of keep your eyes peeled.
Thanks for that answer. We have a lot of questions on the interest of the NAT AMR testing, and that's something that was very exciting to myself as well when Shelley, you presented on that. So one of the first questions that I'll tackle is, can you elaborate on why AMR NAT data cannot be used for individual patient care? And if you have any kind of thoughts on that. Oh, I think you're muted, Shelley.
So, generally, it was developed as a surveillance technique, not a diagnostic technique, which doesn't necessarily mean that it cannot be used for that. It just has not been tested for that. Some of the concerns that I would have with using it for that purpose are just that with an MIC agar dilution, you can actually get an actual level of resistance, whereas this is more of a predictor of resistance and can be a little bit the prediction is not as accurate with cephalosporins as it is with some of the other antimicrobials, and cephalosporins are kind of what we would really be wanting to test for if we're looking for actual patient care. And then the other thing is just that there is also always the potential in the case of a mixed culture or there's the potential for there to be other Neisseria species that could be providing false results. So we are like very confident in this assay in terms of its use as a surveillance tool, but in terms of a diagnostics tool, it really hasn't been tested for that.
Thanks for that answer. And kind of talking more about NAT testing, I'd like to ask a question on like the process for submission. It sounds like a lot of the northern and more remote areas of Canada are submitting a large bulk of these NAT specimens for this AMR prediction testing, but it's not like that's the only regions in Canada where you're getting those specimens from. Is there a kind of process in which hospitals or clinics have to go through to submit this? Do they need a positive NAT test already that's tested in their site and then it goes to the NML, or do they have to organize and submit it through their public health labs potentially? I thought this might be a good area for clarification for some of our attendees in case they are kind of interested in that testing.
Yes, so they definitely need to have a positive NAT already. So we receive remnant NAT specimens that have already been tested. Robin, you might have a little bit more information on where they're coming from.
Yes. So all of our sends are from the public health labs. So they will, some of the smaller provinces I mentioned, like they send us cultures for AST testing, but also they per se don't always just have the resources themselves to do as much culture as they'd like. So they send us their positive nats, and they just batch them by the month. So we only deal with the exclusion of New Brunswick, we deal with the public health labs for each province and territory. And from New Brunswick, we receive from the regional hospitals. So everything kind of gets funneled through the big labs. And we do have on our guide to services, we do have a requisition for this. However, if you are looking to start sending to us, I would ask that you please contact us. Our group email, which we all check, and our NAT lead, Norman Barrero, would deal with, is posted on there as well.
Thanks for that answer. I think we have one more question that was about NAT testing. And it's kind of more specifically if a sample shows resistance due to the presence of a SNP, would this be communicated back to the province and then the provider specifically to facilitate assessment of whether appropriate antimicrobials were used? And I know we kind of touched on that about how NAT testing is more for surveillance and whatnot. But do the results go back to the public health lab for that province and territory then, and then they would decide whether or not to communicate back to the specific submitter if that was a request?
Yes, that would be correct. I, yeah, I cannot speak exactly what the public health labs are doing with the results. Like I know a few of the provinces now are using the results, so we send them as part of ESAG. Again, just depending on what they have available to them in order to build up more of a wholesome picture of what is going within their jurisdiction. So, but if I can't 100% say that it's going back directly to the patient's provider, but we are beginning to look at the use of antimicrobials within a data set sent to us from some of the jurisdictions as part of ESAG.
Thanks for that clarification. So we're going to move and shift gears a little bit with the questions in the Q&A pod to talk a little bit more about resistance and potential changes to guidelines. On a federal level, or if you're aware for at least on provincial or territorial levels, are there any plans to update existing GC treatment guidelines?
I know that the chapter is currently under review. I think that they might be getting close to releasing it. I can't say that for certain what their timeline might be, though, for when they'll release that review.
Great, thanks for your answer, Robin. Another question about the growing concern about resistance. Is FAC moving towards a change? Of course, like this might be related to the updated guidelines potentially that are going to be coming down the pipeline on treatment recommendations to monotherapy. It sounds like CSC made these recommendations recently, so I don't know if this is a question more directed that FAC would be able to answer, especially with the guidelines coming out, or if you have any information you're able to share on that.
I don't have any information I can share on that. However, I don't know the email, but there's probably a group or public-facing email for the STI guidelines group that you could probably reach out to in terms of guidelines, etc., and when they might be releasing that.
Thank you for that answer. We've got a couple more questions in the Q&A pod. One of them is about, has there been any success culturing Neisseria gonorrhoeae from feces that you may be aware of, whether it's from data submitted by one of the provinces or territories, or possibly culture that goes on in the NML?
So we do get quite a few, so we deal with pure cultures. That is exclusively what is submitted to us. However, we do get a subset of our cultures that we receive are isolated from rectums. I can't speak to the state of those swabs. So I'm guessing there's yes to a degree, but I don't think from like a stool sample.
Yeah, that's completely a very fair answer. There's always interesting, specimen source descriptions written on requisitions that sometimes may not actually match how a specimen was collected. Um, and then we have another question in the Q&A pod. Whether Robin or Shelley, are you guys able to generalize are the AMR results for the overall population, given that NAT is predominantly used in Ontario, whether or not that is generalizable?
Um, that's a good question. So that really depends. And so like I said, it's a passive surveillance system. We gratefully accept whatever the provinces, territories are able to send us, both for gnats and cultures. How and who cultures are taken from within each province and territories is up to the discretion of the public health for that province or territory, or even sometimes I think that down to like the clinic level. So there is probably some over like there is probably a focus on certain populations. So it's probably relatively accurate. Yes, Shelley, do you have anything to add?
Well, we did that comparison of gnats and culture data across Canada, and we did find there were a few differences, but in general, the trend seemed to be relatively similar. So I think some of the differences might just be that cultures we receive are from specific areas of Ontario, whereas maybe some northern and remote regions might not be represented in that. So there could be key populations that we're just not covering.
That's a really good point for that. Thank you both for your answers. I have a question that I'd like to ask. Being someone who has had some experience with the MIC prediction tool while I was in Alberta. Um, Being that it's now available publicly in GitHub, are you guys aware of other jurisdictions, whether it's within North America or abroad, that are kind of accessing the tool and utilizing it for their own, Neisseria, gonorrhea, AMR predictions? And, what is the level of kind of relationship building with other jurisdictions for kind of improving, changing the pipeline. And then also, has there been an opportunity to kind of collaborate on potential outbreaks, that extend beyond Canada, with seeing some of the XDR, MDR cases that have cropped up more recently over the past couple of years?
Okay, so I can speak to the tool. As of gonorrhea, I don't know of anybody who's using it currently, but we have been working with some of the other jurisdictions in Canada on getting people to use it for invasive group-A streptococci. So through that, we have had some people making suggestions on things we can update and change, and we've been taking those suggestions into account. And we'd love to have people use it for gonorrhea as well.
Thank you so much for that. It looks like we've answered all the questions in the Q&A pod, and we are getting close to the hour. So I think that we will be concluding today's PHO round session. Thank you so much again to both Robin and Shelley for your insightful presentations. And I'd like to extend my appreciation to everyone who joined us for today's webinar. To access past presentations and view upcoming sessions, please visit the PHO website, navigate to Education and Events, and click on Presentations. Thank you and have a wonderful day.